Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you all again for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine, as well as bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an expert about vascular fistulas, the door to haemodialysis. But before starting, for Australian audiences, listening does give you eligibility for your CPD, so log in and make this an activity. And may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, as a background to this podcast, in 2021, there were 15,200 Australians with kidney failure receiving dialysis, a doubling of the number receiving dialysis from 2000, with a male to female ratio of approximately 2 to 1. 82% of these patients were receiving chronic haemodialysis, all of whom required an arteriovenous vascular shunt for access. A small proportion, 18%, were being managed by peritoneal dialysis, and in that year there were 857 functioning kidney transplants. Of the haemodialysis patients, 25% were being dialysed in hospital, 65% in satellite centres, and 9% at home. Well, Indigenous Australians, representing 2.5% of the Australian population, comprised 9% of patients commencing renal replacement therapy, highlighting a very significant health burden for First Nations people. Well, the main indications for patients receiving dialysis included having severe renal failure with a GFR less than 15 mL per minute per 1.75 metres squared, accompanied by complications such as metabolic acidosis, hyperkalaemia, pericarditis, encephalopathy, intractable volume overload, anorexia with weight loss and lethargy, peripheral neuropathy, intractable gastrointestinal symptoms, or having an EGFR of 5 to 9 mL per minute or less, despite being asymptomatic. Well, vascular access for haemodialysis is accomplished by the creation of an arteriovenous fistula or use of a prosthetic graft with catheters providing temporary access only. As normal veins are not strong enough to cope with the high pump pressures and the rapid blood flow from a dialysis machine, a native fistula joining vein to artery, normally in the forearm, is created. As the fistula matures over 6 to 8 weeks, the vein adapts and thickens, leading to a stable fistula which is ready for use. Both immediate, early and late complications are described, including infection, aneurysm, thrombosis and staphylococcal infection. And despite expert surgery, up to 30% of fistulas fashioned are unusable. The Kidney Disease Outcome Quality Initiative, KDOGI, describes a rule of 6 fistulas, comprising being ready for use 6 weeks or more after being formed, having a blood flow through the fistula of 600 mL per minute, having a diameter of 6 millimetres, accessible for 6 centimetres, and at 6 millimetres depth, the rule of 6. Well, to learn more about arteriovenous fistulas as well as the do's and don'ts of fistula care in primary practice, we welcome back Dr. Ming. Ming is a well-recognised expert in vascular surgery and is the Director of Vascular and Transplant Surgery at Monash Health and Adjunct Senior Lecturer with Monash University. Ming is also part of the Monash transplant team in kidney and pancreas transplantation and brings a wealth of knowledge and experience as well as an effusive personality to accompany his skills. In this episode, he discusses his approach to fistula formation and for their ongoing management and care. Please welcome Ming to the podcast. Dr. Ming, thank you for joining me on Everyday Medicine. What a great pleasure to have you back, Ming.
It has been a pleasure, Luke.
Thank you very much. We're back in the territory of vascular surgery, and there's something that's interested me for a long while, and that is sort of vascular shunts, fistulas, what you do for people who are being prepared for haemodialysis. And we know that there's something like 1,500 people around the country now who are receiving haemodialysis, some of those in hospital, a lot in satellite centres, a small number at homes, but they all need to have fistulas made so the haemodialysis it can be managed appropriately. As doctors, we often see patients with fistulas, but we don't really give a lot of thought to how they're fashioned and, the expertise that goes behind them or how we should even manage them. I know as a younger doctor, I was always told, don't touch that fistula, whatever you do, Crantoc, do not take blood from it. So, but beyond that, it almost represents the dark arts for me a little bit. So I'm very interested to hear your take on fistulas, what we should know about it, the do's and don'ts, and how you create them. So thank you so much for talking to us about this today.
Thank you, Luke. I think before we begin, I just take us back one step just to say that hemodialysis is a form of treatment for people with end-stage renal disease, which basically means that they will not survive if we do not dialyze them in one way or another to clean up the poisonous metabolites in the body.
Yes.
And also a lot of them do not produce urine, so we have to have one way of removing the fluid. So it's called renal replacement therapy, of which consists of peritoneal dialysis and hemodialysis.
Yes.
I think just to touch here, peritoneal dialysis is a process where we put the fluid into the abdomen, achieving equilibrium, and then remove this fluid and put new fluid in. So that's peritoneal dialysis. It's most of the patient can cope with that at home. It gives them a degree of freedom and not attached to the hospital, although the peritoneal dialysis process itself carries some other risks.
Yes.
So coming back for those who cannot cope to do this by themselves, so we have hemodialysis, which means that we clean the blood by a process of the machine. So we have to take the blood out, clean it, and then return the blood. So in an acute situation, we put a catheter in. So it's usually called a Vascular, or a catheter that is often inserted in the neck or in the groin where the big veins exist. And there are two lumens. One lumen is taking the blood out, clean it, and the other lumen return it. So this is usually a temporary measures to get the patient over the acute sickness.
How long can you leave those temporary catheters in for before?
So we do have very occasional patient who runs up of every excess possibility. They can stay on this permanently, but obviously come with a price. Yes. So by and large, a very temporary so-called Vascular, we leave it in for a few days, less than a week.
I say short time.
And then we put a semi-permanent one called a permacath with a cuff that retains under the skin. That can last for a few months.
Right. Okay.
So, but because it is a plastic tube, it comes with the price of infection. Plastic tube blocks up frequently. It doesn't work very well in certain patients because of positions. So it's only a temporary measure. Right. So for a more permanent solution, we create a fistula. So a fistula is by definition, is more or less an abnormal connection between two vessels. We're talking about arterial venous fistula in this situation. We're connecting a vein to an artery. The main reason is that we cannot access the artery repetitively because it damaged the artery. And then when we damage any arteries, the blood supply that depends on the arteries to the tissue, and often is in the hand or the legs, become compromised. So you can get gangrene. So we have to find a way to create a means to take the blood out safely and return the blood back safely. And we need to repeat it 3 times a week. And on each session is about 4 to 6 hours. So the safest way, it has been worked out some 70 years ago, or I think it's 70 years ago, is to create, the simplest is to create a fistula consisting of a vein that we can easily access. So that's usually in the forearm or in the arm. The surface vein is called the cephalic vein. And then we connect it to this artery that supplies the hand, usually the radial artery or the brachial artery. Right. In that way, we share the blood coming into the hand and divert some of it into the surface vein, which is the vein that you can see. And using that vein, we draw the blood out and then return it to the body. So the fistula draws the blood from the artery, and the body compromise by dilating. The arteries compensate by increasing size and promote a lot of blood through the fistulas. So on an average, we say the vein flow volume is probably about 20 mils or less than that a minute. And we need at least 600 mils a minute to go
Yes.
through the veins.
This is
So
one
that
of
we can
these,
draw, yeah.
the KDOQI rule of six. Yeah. That you have to have, it's quite a big volume of blood, isn't it, that's running through
It is a big volume of blood. So the body compensates by increasing cardiac output, means the heart works a bit harder.
Yeah.
Push the blood through into the hand, and then it goes into a high pressure system, which is the artery, into a low pressure system, which is the vein, and return the blood back to the heart. So it's a short circuited a bit in the arm.
How long does it take for the fistula to mature enough?
So when we create the fistula, the vein by nature is a thin wall, low pressure system. So every time you put the needle in, you can potentially damage it, and it can collapse, it can rupture. So we need to give the vein time to adapt to the arterial pressure. That's after it connects up to the artery. So the fistula typically takes 4-6 weeks to, we call it a maturing process, for the vein to adapt to the pressure of the artery, for the wall to thicken, so that when you put the needle in, it doesn't burst.
Yes.
It doesn't create a blowout, so-called blowout in the veins, and basically damage it. So the process takes about 4 to 6 weeks, but in reality, it takes a bit longer, especially in the women population, because the vein tends to be thinner.
Right. Okay.
Yeah.
What percentage of fistulas that you create reach maturity? Is there a failure?
When we say a primary failure rate, means that out of the 10 fistula we create, probably 1 or 2 would probably fail and never proceed any further than that, and then the rest will slowly mature. But even those will probably about a third of it may not function very well. So we need an additional process to help the vein to achieve the target blood flow.
And they don't function well because there's a degree of stenosis.
Normally the flow is too low, so there's inflow problems, like inflow problems from the artery. Because it's an unnatural process of creating a fistula, the body tries to shut it down.
Yes.
So we have narrowings at the joint between the vein and the artery. And because the veins now have so much more blood going through under arterial pressure, it may not adapt well. And so it may thicken and narrow down instead of dilate and open up. So it can create a flow problems, means the insufficient flow coming in, or we have insufficient flow draining from the fistula. So the pressure in the fistula might be too high,
I see.
for example. So when it is too high, it does create a problem with the machine, and inefficient return of the blood can cause what we call recirculation. That means that we don't clean the blood very well.
Okay.
So there are multiple problems with that.
But when you're working the patient up, Ming, someone, a renal physician, is presenting the case to you and asking you to fashion the fistula, and you may have already put in a temporary catheter. What are you doing? You're going to take the radial artery. That's going to steal blood away from the hand. What sort of workup do you have to do to ensure that the blood supply is going to be satisfactory to the hand when that fistula has been fashioned? What do you have to do to ensure?
So the most important thing, of course, is that to create no harm. So when we steal blood from the hand, potentially we can cause ischemia, which basically means not enough blood in the hand. And it can cause gangrene and loss of the digits, or even loss of the hand. So we need to make sure that there's enough circulation going into the hand while trying to create a fistula that has enough blood going through. Nature has given us 3 arteries down the forearms. One of it failed to reach the hand, but there are 2 arteries that does reach the hand, and they are interconnected in the hand. So we have the radial artery on the outside, and then we have the ulnar artery on the inside, and they join in the hand. So when we take the blood from the radial artery, hopefully the ulnar artery will continue to supply blood down the hand. So in that way, although the blood supply to the hand is reduced, but is sufficient to keep the hand alive and functional. So most of them will have a bit of cooler hand.
Yes, I see. Yeah.
But when the problems of ischemia becomes very bad, sometimes we have to reverse it. We have to abandon the fistula.
And you can reverse it. So
we can reverse it and restore the blood back to its original.
Do you have to do a Doppler study of the ulnar artery before you create?
So we do a clinical test called the Allen's test. So
right. Yes.
Usually we block off the arteries and selectively release one and see what happened to the hand. So
yeah. Right.
the Allen's test that is mandatory before we create a fistulas. And we can do an ultrasound if we suspect, especially a lot of patients have diabetes. So if you can't feel the pulses very well, then you probably should do an ultrasound to make sure that the arteries are intact. And obviously veins can be deceptive by just looking at it. And so nowadays it is a routine now. We do what we call a vein mapping. Then we map up all the veins and see what are the size of the veins, which veins are suitable, and whether the vein have any disease in it, like narrowing, scarrings, and previous phlebitis or inflammation.
Are you doing that by venography, or are you doing that by
ultrasound?
Ultrasound.
It's a non-invasive test with an ultrasound.
Right. So there's an increased cardiac output. Often these patients are quite unwell. They've got coronary artery disease, in many instances probably diabetes and widespread vascular disease. It is a situation where you have to often involve cardiologists to assess the cardiac function before you put a little bit of extra strain by fastening. Is that a common? Well, we can't do this. We can't progress because of that. Is that a clinical issue?
In general, I think. In general, we don't routinely refer patients to cardiologists, but obviously if they have angina and unstable angina, obviously they will not be suitable, because that will put a lot of load onto the heart, and they will not be able to cope. If they got congestive cardiac failure, obviously they will not cope. But if they are stable, clinically means they have their heart treated, and physically then tolerates usually daily activities, then we usually proceed without a formal cardiac assessment. So
you've got 2 forearms. Once you've worked through those, if you've had fistula failure, where might you better create a fistula otherwise?
So in general, we try to do it in a non-dominant hand to start off. So usually in the left for most people, so that when they are on dialysis for the 4 to 6 hours, they can use the dominant hands for reading, eating, and things they can perform. So we try to create it on the non-dominant hands so that they have freedom to use the dominant hands. Some people dialyze at home, so they put the needle in themselves, so they need to have the dominant hands to do that. So usually we start with the left. We create the most distal, which means we join up the artery and vein furthest away from the body. That means usually around the wrist. And then we have 1 goal, 2 goals, and then we can progressively move towards the heart at the elbow. So the cephalic veins in the arm is still fairly superficial, means under the skin is easily accessible. Then we do that. If all fails, then we use the basilic veins, which are on the inner side of the arm. Unfortunately, by nature, the basilic vein is very deep, so we need a secondary procedure to move the veins from the deep position out to the surface. So it's called a transposition. So essentially, we have 3 goals on each arm, or 3 types of fistula on each arm. And then if we run out, then we move to the other arm. So if we run out on the other arm, we can move to the leg, usually in the thigh. But that would be fairly inconvenient for the patient, especially. And also, the leg is not as forgiving as the arm. In terms of sharing blood with the fistula, it tends to get into more trouble with ischemia, tissue loss. So we try to avoid that.
Gotcha. We've got quite a few options here.
Yeah.
Tell us what you tell the patient. What advice do you give the patient?
So my advice is generally you can use the arm with the fistula in the normal daily activities, obviously, but do not overstretch it. You should try to avoid taking blood pressure on the same arm because the blood pressure taking, although by itself don't really damage the fistula, but the blood pressure may not reflect the actual blood pressure in the body because of the fistula.
I see. Yes.
And obviously, you should never take blood for checking through the same arm because the vein is now under arterial pressure. So when you put the needle in, you can bleed excessively, especially if one is not experienced in dealing with this, and you can cause a lot of bleeding.
Yes.
And basically destroy the fistula, or you can bleed and cause a lot of problem with problems from the bleeding itself.
Well, that's very important for every medical students.
We tend to, as a blanket rule, try to avoid that sort of thing in the forearm, but obviously we try to preserve as much vein as possible. So if they have to take blood regularly, even in the other arms, they should try to take blood as distally as possible. Try not to damage the vein because it's their lifeline, and fistula don't last forever. So we have to keep progressively improve it, repair it, update it, whatever it means you want to call it. So they pay regular visit to us.
How long will the fistula last on average? Suppose you are very careful with it. You have an ideal patient,
if you are, let's say you are, I'm not being sexist, but usually a young man with big, strong veins and adductive arteries, then that is the ideal situation, obviously. If you look after it, it can last forever.
I see.
Theoretically, it can last forever. But, every time you dialyze, you actually traumatize the vein. You put a huge needle in, you make a hole in the vein, and you expect the vein to heal it over within 2 days before you start again.
There's a lot of trauma, effectively.
It's a lot of trauma, repeated trauma. So there are different technique of putting the needles in. So
Ming, do you talk to patients about listening to the breather buzz that's there and reporting to you if they feel that the sound of the buzz is not as strong, concerns being that the stenosis is developing?
Yes. I think that is a good advice to the patient, especially those who are capable. They should examine their fistula every day.
Yes.
They'll get used to the vibration in the vein, so it's called the thrill. And obviously they can't hear it, but unless you have a stethoscope. But most people can feel it.
Yes.
If they think that the buzz is reducing, then they should see us or see the nephrologist and try to sort it out before it stops completely.
Yes, so that's something we need to be able to. And infections.
So infection generally comes when you put the needle in, and the wounds can get infected. That's usually cleanliness, and so immediately after dialysis, you have a fresh wound. You really need to look after the wound so that it can heal within a day or two.
Yeah, and avoid the staphylococcal infection.
Yeah, so infection is related to the needling. By nature, fistula don't get infected just by itself.
Yes.
Although we do, if you have no veins, we can use a plastic tube to replace the vein. So plastic tube is more liable to get infected. Plastic tubes are more liable to block up. So they are more complications.
Yes. Yeah. But Ming, it's incredible what you do, and this is life-saving to so many thousands and thousands of Australians, and of course in different countries, different people. But in relation to the future, do you see is there a different sort of approach that's being considered to creating fistulas, or are there any other? Is this a standard procedure that's like that you would perceive it's going to continue for many decades into the future, or is the future offering something a little bit different?
I think in terms of creating the fistulas, I think we're trying to do a keyhole surgery. So there is a new technique being introduced.
Right.
It's still experimental in the sense that you try to connect the vein and the artery without performing an actual cuts in the body. You basically try to cannulate it and find a suitable place where the two vessels, the vein and artery, are very near to each other, and try to connect it up and create a hole between them, which is called the fistula. And in that way, you can create a fistula. It's a new technique. Not everybody is suitable. And as I say, still sort of experimental. So the old-fashioned surgery is still very, very relevant. And that's one thing. And obviously, new grafts, potentially a biological graft. If we don't have a prosthetic graft, that might be something that would be helpful in allowing this patient to reduce infection and graft-related complication.
Yes.
There are some on the market, but they're obviously not as good as our open body.
Yes.
And obviously, we're looking for maybe one day we can create a tiny machine and put inside the body. Do the dialysis.
Ming, we're lucky to have you, the wizard of vascular surgery, in our midst here, in this part of Melbourne. I really appreciate you taking the time to run through that. It's a great expose on fistulas, what we should do to manage them, what patients should look out for. Thank you for being so available. I really appreciate your experience and wisdom, and look forward to chatting more about our patients.
It's a pleasure. Look, just in conclusion, I think for people who listen to this program, we would encourage people to consider renal transplantation in terms of donation.
Yes.
And relative friends who can actually donate a kidney, even if they're not compatible, we have programs that can pair people up.
Yes.
A pair exchange program that
yes.
We have an organ deficit at the moment.
Yeah, it's a very important thing.
That's the way to cure the kidney disease.
Yes. Have a new organ. Thank you. That's a very good reminder. Ming, thanks so much for being with us today, and look forward to seeing you again soon. Thank you.
Thank you. Thank you.
Yeah. I'd like to thank you all for joining me in the discussion with Ming on arteriovenous fistulas for hemodialysis. I hope you've enjoyed this and learned as much as I have from Ming's expertise and generous spending of time. Next week, we'll have another very interesting guest. Please join us then during the podcast series, where we'll be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as a general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and they may be emailed to manager@gihealth.com.au. Thank you.